What I'm going to do to start out with is talk about neurostimulation, kind of just go through a brief overview of it, and go through a little bit of the history. And if you have any questions, please feel free to speak up. I want this to be very informal, so chime in. All right. So for those of you who don't know where Mount Tam Orthopedics is, it's right across the Golden Gate Bridge from San Francisco, about 6 miles up the road. And as Glenn just mentioned, I've been in academics for the past 6 years, and just moved to private practice and working with 12 orthopedic surgeons embedded with them. So business is good right now. Financial disclosure, I have received honoraria from Abbott, Halyard Health, and Sonosite. And so I will be demonstrating and talking about a lot of their products and other people's products, of course, as well. As far as our table of contents, I'm going to go through the background of neurostimulation, the covered diagnoses, the SAFE principles, failed back surgical syndrome literature, vendors, societies and journals, decisions and outcomes, and then we've split off the case studies to later on in this talk. Historically, we had it at the end. All right, so one of the big challenges we have as pain physicians is really describing what we do. And one of the things, we're always encouraged to do in medical school is talk to your patients as if it's your grandmother. How would you describe this technology or this modality? And so this is a very generic definition, but basically we're providing electrical current to an electrode that resonates at a specific frequency or waveform now on the spinal columns to mask pain, okay? Frankly, we don't know exactly how spinal cord stimulation works, just like we don't know how acetaminophen exactly works. So it's another one of those mysteries. It's frustrating to your parents who've spent thousands of dollars on your education and you're telling them about something you don't know how it works. But nonetheless, we've seen it work. We have the randomized controlled trials to demonstrate that it works. So without further ado, if we go back to our medical school training, remember our nerve fibers. Which ones are we most interested in as pain physicians? Perfect, you're awake, E delta and C. So back in the 1960s, as you all probably have already read, Melzek and Wall came up with their gate theory or gate control theory in 1965. And the idea was if we turn on A beta stimulation, touch and pressure, what we'll see is interneuron inhibition of the C fibers. And that therefore could reduce the nociceptive input up the spinal thalamic tract. And what's really interesting about that is very shortly after, Norm Shealy places a unipolar spinal cord stimulator lead in the intrathecal space. Basically an application of this theory only 2 years later. If you think about many medical theories, it usually takes 10, 20, 30 years before you see it applied clinically. But when it came to spinal cord stimulation, that gap was very narrow. And here was that article. Norm Shealy was a neurosurgeon who was practicing in my home state of Wisconsin. He was at Gunderson and La Crosse. He tried to get this paper where he used an intrathecal lead sutured directly onto dura into neurosurgical journals. He couldn't get in, so he got into anesthesia and analgesia, hence the birth of neurostimulation in modern medicine. This case report was fairly interesting. It was a woman with very advanced metastatic cancer who was having intractable pain. He had been working with his research colleagues on this theory of using electrical stimulation to reduce pain. As you can see, he sutured the leads directly into the dural space, and then it was connected to a large generator outside of the body. Remember, you didn't have an implantable pulse generator, you didn't have a battery, you didn't have wireless. So that patient unfortunately succumbed to infectious complications 2 to 3 days later, but they report that she had good pain relief for a little while. All right, so since then, since Shealy in 1971 in Japan, epidural electrodes were used. Moving forward through the 70s, it went from single or double contacts to a 4 electrode array. In 1981, we finally have the implantable pulse generator. Now we're able to put everything under the skin. In 86, we went to 8 electrodes. In 88, now we use more than one lead. In 1994, we're able to recharge our batteries. In 2007, Medtronic comes up with MRI conditionality, which everyone has realized is a very important issue. 2011, Boston Scientific has a 16 electrode arrays. Medtronic has positional sense. And then in the last few years, you've seen a huge explosion in innovation. So we've seen high frequency stimulation, the 10 kilohertz algorithm from Nevro. We've seen different patterns such as burst and high density and everything else. 2016 in the United States, we got dorsal root ganglion stimulation, which we'll talk about later. And then in the future, the next thing is feedback systems. It's a really important and great time to be in interventional pain management. There's been a huge explosion just in the last few years. When I was a fellow, that was back in 2011, we didn't have any of the stuff you have now. Basically, you had 2 leads, 8 electrodes per lead, and an IPG, and tonic stimulation. That was it. Now you've got high frequency, burst, DRG, and the future is looking bright as well. All right, so with the gate control theory now, 52 years old, it doesn't explain everything because what we've seen is that when you turn off stimulation, there still is this continued relief that can occur for hours, days, and for some individuals, they'll claim for weeks. So what else could be going on? Well, it could be activation of these descending inhibitory pathways, the fasciculus interfascicularis, the septomarginal fasciculus, or the dorsolateral fasciculus, or the corticospinal tract. It could be neurotransmitters like GABA, substance P, serotonin, glycine, adenosine. But these are theories. We're still trying to figure it out. But there's certainly more to it than just the gate control theory. We have lots of things, bells and whistles, to play with. So these are the parameters we think about when it comes to our stimulators. You have anodes and cathodes, so those are basically the contacts you can see in the pictures there. You have cylindrical leads or percutaneous leads. Those are those bottom 5 or so that you see there. And then you have the paddle leads. So the paddle leads are unidirectional. They emit their electrical energy in one direction, whereas the percutaneous leads are cylindrical or circular field. The frequencies, generally with traditional systems, your range was 2 to 1200 hertz. As you probably have heard by now, we have high-frequency systems that allow you up to 50,000 hertz. Geimer's even talking about 500 kilohertz. Pulse width, that's something you'll talk about with your programming as far as how wide the pulse is and how it changes the electrical field. Amplitude, the pattern itself, and then really it's an understanding of the conductivity of a substance because you all remember Ohm's law. So while you have all these parameters to choose from, then you have your technique and your placement of your leads and all of those factors to deal with, and then you have your individual patients to deal with as far as their condition. So as a reminder, this is probably the one slide I really like to remind you of that you may never see again. But really our biggest resistor when it comes to the difference between your lead and your target neurons is CSF. So what happens with cerebrospinal fluid is it dissipates that electrical energy away. In systems where you have reduced CSF volumes, you might be able to address those neurons with much lower energy requirements. But as you know, position can make a difference. The anatomy of an individual can make a difference, whether they have stenosis or they don't. So do remember that. And then as far as the conductivity of other substances, as you can see, it's on the order of 10-fold reduced or 100-fold reduced. So not as much of a dissipator of your electrical current. There are different waveforms. So traditional refers to your tonic firing, which you can see here. So if you just simply had the same rhythmic tapping at a certain frequency. Burst stimulation is the work of Dirk de Ridder from Belgium, Netherlands region, where he found out that there were certain neurons that seemed to fire with this burst pattern, particularly in the thalamus. And his theory was, what if we spoke the language of those neurons and fired that back with spinal cord stimulation? So he developed this algorithm in a charge-balanced fashion, and sure enough, it actually worked. And what was more interesting, it was a paresthesia-free stimulation. Similarly, high frequency or 10,000 kilohertz stimulation from Nevro, we don't know what the waveform looks like because it's proprietary, but it also provided paresthesia-free stimulation. All right. Have any of you heard of the SAFE principles before? All the UCSF fellows, I'm sure, are going to raise their hands. So SAFE stands for safety, appropriateness, fiscal neutrality, and effectiveness. So we're going to go through these principles, and it's actually a very useful set of principles to apply to any medical technology. And the reason for this is these technologies are expensive, they're invasive, They are fraught with complications. And so if you're going to choose to go down this road, you really have to take into account all these issues. So we'll go through each of these one by one, and I'm really going to focus much of this talk on failed back surgical syndrome because that's the primary indication for spinal cord stimulation in the United States. So I'll first start out with safety, or the S. Krishna Kumar was a neurosurgeon in Canada. He unfortunately passed away in the last year or two, but he was basically one of the neuromodulators for Canada. And he had one of the largest cohorts of individuals to study because he was like one of very few individuals in Canada who was doing all this. And he provided a lot of the literature that was foundational to our field. And in 2007, he came up with these rates of complications from his own case series and throughout Canada. And number one, as you can see, was lead migration, okay? So that's when the leads move on you and you're not able to capture the stimulation location that you want. Now, leads can move a little bit, of course. People will move, but as long as you're still in the same range of those contacts, you'll be fine. But if it slips all the way down, that's a problem. 9.1% rate of lead breakage. Again, so this paper came out in 2007. He was dealing with primarily Medtronic systems from the early 2000s. Device malfunction, 2.9%. Infection rate of 4%. Neuroaxial hematoma, 0.3%. Epidural puncture or CSF leak. And he was a neurosurgeon, so he was doing paddle leads, 0.3%. Undesired stimulation, 2.4%. Pain over the implant, almost 1%, and skin erosion. If you add all this up, that's 1 out of 3 patients are having a complication. It's not okay. If we are to talk to our patients and we tell them there's a 1 out of 3 chance they're going to have one of these complications, very doubtful they're going to really want to sign up for this. So one of the things that's really important is getting the experience of doing these procedures. Being here today is a good start, getting the education, getting your hands on the cadavers, because the more and more you do this, the more and more your complication rates are going to go down, down, down. And now you see neuromodulation articles where the infection risk is 1% or 2%, depending on that institution's practice, or the lead migration rate is 0.2%, depending on which articles you read. So we've done a really good job getting those complication rates down, but that's because of articles like this, telling us, hey, here are the problems, and these are the issues we need to do to fix them. All right, so what are the covered diagnoses? Appropriateness, the A in SAFE principles. So you're going to see your patients in your everyday practice, lots of different pain conditions. And although you could memorize a list of all the indications, I really break it down into neuropathic pain syndromes and ischemic pain syndromes, or ischemic conditions, I should say. So the neuropathic includes FBSS, complex regional pain syndrome, radiculopathy, occipital neuralgia or cervicalgia, phantom limb pain or residual limb pain, diabetic peripheral neuropathy, postherpetic neuralgia, although the outcomes aren't great for that, but it is a covered diagnosis, chemotherapy-induced peripheral neuropathy. Interestingly, if you go to Europe and other countries in Asia, they will say that they use spinal cord stimulation primarily for peripheral vascular disease or for angina. It's actually part of the cardiology guidelines in Europe and even in the United States for refractory angina that's refractory to medication management. So even though we may not be doing this very much in our country, it is certainly something that's used internationally. Because as we know, by creating C-fiber blockade, there's a sympathetic vasodilation that can occur peripherally depending on where your leads are placed. All right, so fiscal neutrality and cost effectiveness. Do you guys know how much these systems cost approximately? Throw out some numbers. Okay, good. 25,000. What else? What do you guys think? 40. 29 to 38. This guy's the price is right. $1. There you go. There's a smart guy. So he's looking at my slide. That's not even right. So yeah, depending on which vendor your contracts, it can be anywhere from $20,000 to $40,000, and maybe it's upcharged depending on, again, that contract. But these are expensive devices, okay? And so we really do need to look at fiscal neutrality and cost effectiveness. If we're throwing money down the drains as a group of pain physicians, this is not going to survive, okay? Everybody's putting us under a microscope, and rightfully so. So we should be able to prove that we are cost effective and we're doing what's right for patients. Again, Chris Kumar, this was an older study, 2002. He looked at the 5-year costs of spinal cord stimulation patients that included all of their healthcare utilization, and compared it to conventional medication management or conservative treatment, which included imaging, PT, chiro, massage, hospitalization for breakthrough episodes, and found that the conservative group actually spent more. And the cost of SCS was greater for the first 2.5 years because of that upfront cost, but once you went past 2.5 to 3 years, you started saving money for that individual. And we have a graph of that here. So if you can maintain implantation for at least 3 years, I will say, you are going to demonstrate cost effectiveness. So that should be one of the goals you look at. This is specifically looking at a failed back surgical syndrome population. All right, so about this diagnosis, it's a horrible name, right? It has the word failure in it. We throw it around like it's no big deal. But that's really not doing any justice to our surgical friends. Pain after surgery is not necessarily a failure, right? We don't call it failed mastectomy pain syndrome or failed thoracotomy pain syndrome, right? Every surgery is a risk for the development of chronic pain after that surgery. This is used in all of our, ICD-10, ICD-9 coding, but it's pretty harsh. So when you use the term, understand what it really means. It's basically a waste basket of a lot of different things. We should remember that pain is both an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So when it comes to patients with chronic back pain, which is the #1 reason people have pain in the world according to the global burden of disease, and then a surgeon chooses to operate, there might be a lot more to it than a spondylolisthesis at L4-5. There might be that emotional overlay, which we may need to address as well. So what about this syndrome? What are some of the issues that could be going on if we dig in deeper? Well, as we know, there could be postoperative epidural scarring and fibrosis. There could be a redistribution of spinal stresses to the facets, the sacroiliac joints. Could be arthritis, could be muscle spasm, could be a recurrent disc prolapse or discogenic pain. I mean, we use this term, we throw everything in, but it's really important that we start to parse out what is what, and sometimes it's really difficult. Even with the best imaging studies or diagnostic testing, you can't necessarily figure out if it's that disc, or if it's muscle spasm, or if it's arthritis, or even if it's arachnoiditis. So all of these things could be happening. So when you do studies with spinal cord stimulation and we're saying the indication is failed back surgical syndrome, it could be addressing any one of these things. And the question is, are some of the failures we see because we're not able to capture some of these issues? Like, for example, arachnoiditis. That might be a very challenging thing to address with spinal cord stimulation. And then lastly, just neuropathic pain. Whether the surgeons operate there or there was a traumatic injury to the back, if those nerves get damaged, will they just develop a neuropathic pain cycle that we must address? So what does our literature say? This is a brief review of the last 25 years or so. So going back to Richard North, looking at spinal cord stimulation versus reoperation. I just did a highlight of some of the papers that came out between 1994 and 2015. But really, in the last couple years has been where the field has understood we needed to have randomized controlled trials. Prior to that, we had case reports, match controls, comparing to another surgery. We never really had sham control. We still haven't had sham control studies done yet. But we've understood that our study designs needed to improve, and part of the challenge was getting the patients, the sample sizes large enough to prove benefit. But with the Senza trial done in 2015 for HF10, that's where we were able to compare it to traditional tonic stimulation and prove that there was some benefit with that modality as compared to tonic stimulation. All right, so there are currently 6, and maybe even more today, who knows, they're popping up every day, companies with spinal cord stimulation systems. I mentioned the 6 that I know of here. I guess most of them are out there. There are other systems coming out looking at peripheral nerve issues, and we can talk about that offline if you'd like. I try to keep track of a gross comparison of these systems. Again, there might be some errors because every week there's a new update. But one of the major issues that has been raised in the last 5 years is MRI conditionality. Okay, it's important to note that it's not MRI compatibility, it's conditionality. None of these systems can state that they're compatible because if there is a lead fracture or some issue or a manufacturing defect, it may still not be safe for MRI, even though they're considered MRI conditional. So the conditions are there isn't any damage to the lead, that the MRI is done in a certain way up to a certain Tesla with the right coils, et cetera, for the right locations. So those are all the conditions you need to look at when you hear that a system is MRI conditional. And it's really important to dig deep because if a patient hears, oh, this system is fine with an MRI, and then sure enough they try to get an MRI of their, of their back, but it's only for head and extremities, they're going to be upset. So really understand that all the companies are trying to get total body MRI conditionality up to 3 Tesla. But right now, pretty much everyone has 1.5 with certain stipulations, as you can see here. As far as paddles, again, they've been working on that as well. The number of contacts, some slight variations, generally 16, 32 for Boston, 24 for New Vectra. The IPGs all have their bells and whistles, which they can all tell you about. Boston Scientific has their zero charge IPG. Abbott has their primary cell, which lasts for 5 years. And then the voltage versus current debate really has kind of gone away now that the latest Medtronic system is using a current-based system. They historically were all voltage, which was, not to be too critical, sort of a problem because with a voltage-based system, as you develop more scar tissue or resistivity, you lost efficacy. So if the patients didn't come back to get reprogrammed, they just felt like they weren't getting good relief. So they moved to a current system or a current-based control system. And then patterns, as you've already heard, you have tonic stimulation, you have burst, you have proprietary 10,000 kilo or 10 K hertz, and then Nevro, or excuse me, not Nevro, but New Vectra says they have flexibility for all of these different waveforms. As far as dorsal ganglion stimulation systems, there's only one right now on the market. Historically, that company was called Spinal Modulation out of the Bay Area. They were purchased by St. Jude Medical, which last year converted to Abbott. And so as far as these systems, they just displayed their new platform called Proclaim DRG, which is MRI conditional to 1.5 Tesla. The old spinal modulation systems were not MRI conditional at all. And then up to 4 quadrodes and current and tonic. So what's coming up in the next couple years here that you're going to hear a lot about, especially if you go to NANS or any other conferences, is really about feedback mechanisms. So as I mentioned, you have electrical stimulation from a percutaneous lead coming down to your dorsal columns. That's nice through the CSF. But what if you started getting feedback from those neurons? And could that then be help that system adjust their amplitude or their pulse width because of positional changes or movements so that stimulation could remain within a therapeutic window? So Saluda Medical has been looking at this, and they presented their data at the International Neuromodulation Society in Edinburgh this past summer. And what they did was they had closed-loop feedback simulation in the upper left-hand corner, as you can see here, and then they can take off the feedback mechanism. What's really interesting about the system is they basically used a Medtronic platform, so tonic stimulation. Nothing special about it besides the fact that it had feedback mechanism available. And when they turned it on, they had the patients do all of these positions and cough, and the stimulation remained within a therapeutic window. They actually had a video of the patient doing all these things. And then when they turned off open or went to open loop or took off the feedback, like the patient would cough and they go, oh, they'd feel it because of that change in their Valsalva pressure, or with Valsalva and their intrathoracic pressure. And so it's kind of cool if you think about it. Turning on this feedback mechanism can really help patients maintain that therapeutic window. And so with positional changes, or if the leads move for some reason, whether it's a cough or a sneeze, you're still going to be in that nice range. So I think you're going to hear more and more about that in the next year or two. All right, so who is doing spinal cord stimulation? This is a fairly old slide, but nonetheless, it gives you a sense of who's doing what. This is back from 2009. So depending on what you describe yourself as in your CMS website, as an anesthesiologist or interventional pain management physician, these are the breakdown of physicians doing CPT code 63685, which is the battery or IPG placement. And what's interesting to note with the trends over the years is that you're seeing more surgeons doing spinal cord stimulation, both in neurosurgery and orthopedic surgery. And that's because with more and more studies coming out about this technology and the outcomes, it's now an option for those individuals who have a spine surgery and don't do well. So they realize, rather than just saying, well, we can either reoperate or do nothing or give you a bunch of opioids, now they have this other option. And so I think, currently we're seeing about a 50-50 split in surgeons to non-surgeon specialties, but nonetheless, this gives you a good idea of who is doing this. All right, so if you're not already involved in these societies, I think it's, as a fellow, you should be involved with every society, I think, because either it's free or it's like $20, and then you get access to everything, the journals, et cetera. And then if they forget to realize you're a fellow, that might last for another year or two, by the way. So I highly recommend doing it for every society you can. The North American Neuromodulation Society is the North American branch of the International Neuromodulation Society. Their annual conference is now every January, and for the next 2 years will be in Vegas for sure. It's a really fun conference, very unique among all of the pain conferences. I go to ASRA, IASP, all sorts of AAPM, APS. I go to lots of different pain conferences, but this is really fun. Probably because of the technological aspect of it. About a third of the crowd are PhD basic scientists, a third of the crowd are clinicians like myself, and a third of the crowd are venture capitalists who are trying to jump onto what the next big thing is. The International Neuromodulation Society has their meeting every 2 years. This last summer was in Edinburgh, which I went to. It was a ton of fun, really interesting to meet European colleagues, Australian, New Zealand colleagues doing a lot of this. Because FDA approval for a lot of these studies is far more rigorous, so a lot of the initial pilot studies are done in other countries, even if the technologies are made like in California. So that was true for Nevro, that's true for Saluda, and many other technologies. Every year the IASP has their global year of something. This year it was against pain after surgery. And certainly with spinal cord stimulation, particularly dorsal root ganglion stimulation, there's definitely a niche for these technologies for the Global Year Against Pain. I think 2018 is the Global Year for Pain Education. So every year there's a new focus. Really the IASP and the APS try to direct their political efforts regarding that cause. So if you are interested, you should look that up on the IASP website. As far as the journal, I think neuromodulation is probably the leading journal in this field. Certainly, you'll see articles in other journals like anesthesiology, ANA, et cetera, neurosurgical journals. But neuromodulation really was a super thin journal when I was a fellow, and now it's obviously expanding and the content is becoming better as the studies improve. And I'll do the last 5 minutes here talking about how to make decisions, because I think that's something that is super important when it comes to this technology or these technologies and your future. Some of you may be here thinking, I'm definitely going to do stimulation. This is definitely what I want for my future practice. Others of you might say, I'm not so sure about that. I think I said that 1 in 3 have a complication. I heard about this scary case. I don't want to do this ever again. And some of you are here just to say, I just want to know who I should refer to. I'm not interested in doing this at all. And that's totally fine. We don't expect everybody to be a neurostimulator or do implantation or all the techniques we teach this weekend. But nonetheless, I think it's really important to have a good framework for the decisions, not only for yourself, but for your patients. So this is a great article. If you haven't checked it out, I recommend checking it out. It talks about the complexity and the unknowns, the knowns, as far as how do I make a decision that's best for me and for whatever situation. Obviously, for HBR, it was regarding companies, corporations, et cetera. But I think it's a nice primer on how to make a nice decision. And if you weigh these risks and benefits, we look at the risks associated with neurostimulation, which we've gone over. We've talked about the benefits, obviously, pain relief, functional improvement, improved quality of life. And then you look at other therapies, or where would that patient go if they didn't have neurostimulation? That's the big seesaw. Because as many of you know, we're in the midst of this opioid epidemic. And we're all familiar with all the side effects on the left-hand side. But what happens with those patients if they're taking an opioid for 6 months, 12 months, 5 years, 10, 12, 20 years, as some of you have seen already? And not only are we not seeing necessarily improvements in their pain since they continue to take higher and higher doses of opioids for some of those individuals, we're seeing a lot of these other issues, many of them not explicitly discussed, like hypogonadism or low testosterone or amenorrhea or immunosuppression or all the other issues that you certainly are familiar with, such as tolerance and abuse and addiction, which is really what the national spotlight is on. But I'm actually more worried about the other issues because I think of opioids like hormones in that we have an endogenous system, you give an exogenous substance, and it's going to completely hijack the endogenous system. So it's going to lead to issues with what concerns me the most, hyperalgesia, the very concept of making your pain worse over time, and then all of these other issues mentioned here. So it's not to say opioids are the devil, but we have to take all of these issues into account when we choose what we're going to do. And as I've already alluded to, we're in the midst of this opioid epidemic. We have our latest data for 2016, which just came out 2 months ago out of the CDC, showing that we're now almost over 55,000 opioid-related deaths total. And the huge uptick has been in the synthetic opioid analgesics like fentanyl, carfentanil, et cetera. All right, and just more visualization of the epidemic we're dealing with. I mean, this is from 2000 to 2004, 2005, and then going up to 2008, 2009 at a county level, looking at opioid-related deaths. Actually, this was looking at all poison-related deaths, but the authors noted that for cocaine, alcohol, and basically every other substance, those were basically steady over these years, but it was prescription and non-prescription opioids that really accounted for these major changes over those 10 years. All right, so with that sobering discussion on opioids, now the question is, all right, Ramo, I want to do neurostimulation for my patient. You've talked about all these forms of stimulation. There's spinal cord stimulation, there's dorsal root ganglion stimulation, there's all these patterns and frequencies. Which one do I choose? So as I mentioned, for spinal cord stimulation, I think you really want to group it into neuropathic and ischemic conditions. When it comes to what I call the paresthesia-free stimulation patterns, I think, I'm sure there already are studies looking at both, but generally I think of them fairly similarly in that they're paresthesia-free. The outcomes in my experience have been very similar with both, so I think they're both very good. I think they're covering a component of back pain that we had not seen with traditional spinal cord stimulation, and that is axial back pain. Because historically, if one had FBSS, we would tell patients, well, we can address your lower extremity radicular pain, but we weren't sure if we were going to address their axial pain. Now with paresthesia-free stimulation, I'm implanting patients who only have axial back pain, and we're seeing great outcomes. Dorsal root ganglion stimulation, I'm going to talk a little bit about in 9:30, but it's very different. We use it for very different indications, such as, well, CRPS does have overlap, but very specific dermatomes, and then persistent post-surgical pain syndromes, and then mono or oligoneuropathies. All right, and I strongly suggest measuring your outcomes over time, whether that's doing studies or having a registry. In my new private practice group, when I was interviewing with them, one of the things that appealed to me most was the fact they keep a registry, a totally transparent registry of all their outcomes from their spine surgeons. And I said, hey, can I get in on that for spinal cord stimulation? And they were like, absolutely. So we have someone who manages a database just to see how our patients are doing. There's so many parameters to look at in questionnaires and surveys. I personally have chosen the World Health Organization Disability Assessment Score and the BPI. You can look at quality of life through the SF-12s or 36. You can look at medication use risk or opioid abuse risk or misuse risk with the SOAP or the COM. You can look at their depression, anxiety, catastrophization, and at the bottom are your pain assessment tools. Frankly, patients don't like doing these things. It's time consuming. They just find it onerous. But if you explain to them that it's helping future patients, it's helping us understand if this really is working, then they're more willing to do it. So I just keep it to 2. I don't give them the full battery or else they'll hate me and never come back. But I keep it to the BPI and the HUDAS 2.0. All right, so to summarize in the last couple minutes here, neurostimulation is an effective method to manage pain. We've seen that now with the Senza trial. With the current epidemic of opioids, other therapies need to be considered. The goals of care, as with anything in interventional pain or pain management as a whole, are to improve function, reduce analgesic medication use if they have significant side effects, and improve the quality of life. Selection of candidates must be scrupulous. That's your job, is really to figure out who is a good candidate and who is not. And it is costly. As we talked about, tens of thousands of dollars. We have to demonstrate cost efficacy and work to reduce the cost of implantation and complications associated with it. And you sort of have to take a leap of faith if you're interested in this area, because if you don't get into it now, the technology will be way advanced 10 years from now, and you're not going to jump in then. So if you have any inkling for this, get in now, because you're going to see things really take off, so you really want to grab those coattails. And remember these SAFE principles. I think they're really important, not only for neurostimulation, but for any new widget that comes up in pain medicine, to really apply these and understand what is good for your patients.